And thanks to the All India Ophthalmic Society for giving me this opportunity to present my topic here today. I have no financial disclosures relevant to this topic. I want to present initially a first case report, which has relevance to the topic I'm going to present. An 8-year-old female was bilaterally pseudophakic with type 2 diabetes mellitus of 20 years duration, presented with a history of diabetic macular edema of 2 years. Of significance was she had lots of comorbidities, like coronary artery disease, to name some few, a heart valve replacement with coronary artery bypass graft, and also a history of mini stroke in the past. So we did an OCT scan, and the OCT scan showed central retinal thickness was greater than 400. So she was eligible for treatment with an anti-VEGF agent, because in England, the National Health Service, people are eligible for treatment only if their central retinal thickness is greater than 400. But she had the first injection. After that, she was lost to follow-up due to intercurrent illness. And then she was reviewed after 6 months and scheduled to have a second course of anti-VEGF agent. But in the interim, she again developed some systemic problems like ischemic heart disease. She presented 18 months later after the initial episode on a wheelchair. So she first walked in initially, and then she later presented on a wheelchair, strapped securely with an indwelling catheter. So at that stage, I decided the best option in her case would be to treat her with an intravitreal fluocinolone acetonide implant. She had that, and the response was very spectacular. And within a couple of months, macula went dry, and then in the last 16 months, 24 months follow-up, she still maintains a dry macula. The two big societal burdens of treating a retinal disease, and we're grappling with this problem, is of treating wet age-related macular degeneration and diabetic maculopathy, along with the small component of vascular disease like vein occlusion. The patient profile is quite different. That's important to understand. Patients with age-related macular degeneration, it's basically a local disease as compared to patients who have diabetes. It's a multi-system disorder. So patients come to hospital for various reasons. If they're diabetic, they have to meet the endocrinologist. If they have poor sugar control, they have to see the diabetic nurse practitioner in primary care in England, of course. They may have to see the cardiologist and come on alternate days for renal dialysis if they've got renal failure. And the least we can do is to subject them to further visits as a retinologist to have more anti-VEGF injections. So why this holistic approach for treating DMO? I think it's a multi-system involvement. It's not just an eye disease, it's a systemic disease. The care has to be individualized to the particular patient, and the best we can do is to reduce the burden of these patients visiting hospital. What are the treatment options we have at the moment? Well, we have a conservative treatment. Not everyone needs treatment. Then you have thermal laser, you have anti-VEGF, and you have the steroid implants. But unfortunately, the anti-VEGF has taken a center stage at the cost of steroid implant. We've got two implants. One is the dexamethasone implant, which works very well. It has to be repeated in about 3 to 4 months' time. And then you have the fluocinolone acetonide implant, which stays in the eye for roughly about 3 years. But practical terms, after 2 years, they may need to have a top-up with the anti-VEGF or a repeat injection of Iluvien. So there's plenty of evidence in the literature showing the efficacy of all the three anti-VEGF agents, so there's no doubt about it. But what about the visual outcome with the anti-VEGF agent in real-life world? Does it mimic what we see in RCT? The answer is probably no. There's a paper which came out from North America a few months back, which looked into 15,000 patients, and when they looked into the outcome of patients treated with anti-VEGF, they found that the outcome was meaningfully inferior, not superior, inferior to those noted in RCTs. And it didn't really matter what anti-VEGF agent was being used. So let's go to the conservative management. I mean, patients sometimes come and say they don't want any treatment, they're afraid of lasers, they're afraid of injections. So they just want to be followed up, so they don't want to be discharged. So look at their risk factors like glycated hemoglobin, the blood pressure, the cholesterol. But don't forget anemia. Anemia is an important factor. It can also increase the progression of retinopathy. So in type 1 diabetics, there's a possibility that they can have, being an autoimmune disease, pernicious anemia. And in type 2 diabetes, they can have anemia of chronic disease. So look at anemia and treat it and inform the physicians if that's needed. Laser works very well, and this is a patient who had a center involving CSME, and in spite of that, I treated her because the CRT was less than 400, so she was not eligible for treatment with anti-VEGF, and after 2 courses of focal laser, she responded very well. Now, the important question is, patients cannot come to hospital on every occasion. You have a patient with a cardiac failure with pulmonary hypertension. You can't subject him to treatment with an anti-VEGF agent with frequent hospital visits. So I switched this patient to a dexamethasone implant, and the patient seems to be doing well, and the macula has been relatively dry over the years. The important thing is the implant, which is the fluocinolone implant, which works fantastically. It's not got much press. People have not looked into it because of many reasons, which I'll come to the next few slides. And this is the patient. If you look at the macula on the left-hand side, it looks like a terminal macula, which is gasping. And one would say that patients will not sort of have any improvement with any form of treatment. So I gave a fluocinolone acetonide injection, and after 12 months, the retina is completely dry, and the vision is picked up to about 30 letters, better than what she had when the patient presented with 23 letters. And relatively, the patient has been stable with a fairly stable visual acuity. You can also do a bilateral intravitreal implant, which seems to do very well, and they seem to tolerate this injection well as well. The 2 factors which has been implicated as problematic being the cost with the steroid implant, but there's an economic model which has been worked out by a group called Coutinho et al., and they looked at the costing of a steroid implant versus anti-VEGF agent, and it seems that the cost long-term is comparable, so it's not increase in terms of the cost when you compare the anti-VEGF agent. So in fact, I did a paper recently which presented it and looked at the cost analysis comparing 3 years aflibercept versus a switch to fluocinolone acetonide, and at least in the short term, in 2 years, there has not been any increase in the cost, and the cost is quite comparable with an anti-VEGF agent. The 2 factors which is again said that is a problem, because you give steroids, one disease being treated, and you create another disease like glaucoma and cataract. And in fact, in the FAME trial, when they looked at it, they found that the incidence of cataract is no different from the general population. And glaucoma, of course, you get that in 20% of patients, but this is quite easily treatable with a single drug in most of the instances, if not a second drug, and about 0.2% or less will need an incisional trabeculectomy. So I would say that you should always consider intravitreal triamcinolone as a first option in certain group of patients. And as a hindsight, when I look back, I thought my patient probably would have benefited by having an illumin implant rather than an anti-VEGF agent. So patients who have multiple comorbidities, who have poor mobility, who are wheelchair bound, patients who can't make frequent visits to hospital due to renal dialysis, they have a mild cognitive defect, or they have transport problem, which is quite relevant, not just in undeveloped countries, but can happen even in developed countries like England. So in conclusion, I would say that don't treat diabetic macular edema as a disease in isolation. It's not a disease of the eye only. Consider the patient. Don't just focus on the retina. Consider steroid implant in suitable patients. Thank you.